Good afternoon, folks. We're continuing with that competency theme. So my name is Roxanne Nelson. I'm a Justice of the Peace in Burnett County, and I'm also a commissioner on the Judicial Council on Mental Health. Our next session is Competency Restoration at the Ground Level, a View from the State Hospital, focusing on hands-on experiences and practical insights from this Terrell State Hospital. The presentation offers a detailed look at the strategies employed to assess and address the needs of patients undergoing competency restoration at Texas state hospitals. Dr. Mark Messer is the superintendent and medical director at the Terrell State Hospital. Please welcome Dr. Messer.
Thank you. I sure want to say, I want to say it's absolutely an honor to get to speak with you today. And I heard some of the last presentation, so I'm going to try not and just wear out a clearinghouse list. I'll make that as quick as I can, but let me just kind of give you a broad overview. I'm not sure how much everyone's aware of the state hospital system. There are 10 state hospitals in Texas. I'm at the Terrell State Hospital. It's just southeast of Dallas. And we're actually licensed for 305 beds, but our normal census runs around 210, somewhere in that range. And obviously I'm biased, but it's certainly amongst the top of the state hospitals, and I can give you some examples coming up. The competency restoration system we at Terrell actually have a very good system that I'll kind of give you some description of. But before I do that, let me mention, in the bigger cities, Houston, Austin, Dallas, San Antonio, you realize that's the same patient population in terms of severity of illness amongst all the cities. It's basically the same patient population. But without trying to commit professional suicide here, there's an outlier city where you would think the jail waiting list would be based on the population of the city. There's one about 10 miles from here, I guess, where there's an inordinately high number of people deemed incompetent. And when you look at the numbers for the other remaining bigger cities, you see that perhaps there's not a inter-rate or reliability or consistency amongst what is really incompetence to face the charges pending against them. There's certainly the legal definitions, that the person is able to form an adequate defense with their attorney. They understand the adversarial nature of a courtroom. Excuse me, all these things to maintain the purity of the justice system. And I've tried to look at that from several ways. The waiting list in Dallas is quite large. And of course, those are people waiting on open beds at my hospital, and I'll go into that here in a moment. It does, I guess, slow the system down, but you could argue from a long-range perspective, those people might end up getting better care. I don't know. I don't really know the answer. We've thought about this for years. Is it better to have a low threshold to deem patients incompetent? I don't know the answer. I guess that will be debated for some time. But when the patients are brought to our hospital, we have a very strong restoration program where our rehab department actually has 3 tracks for the patients to go through. The patients that are almost there, the quote, low-hanging fruit, those that wouldn't take a lot of work to restore, they get put on what we call a fast track, where we actually have an employee work with them one-on-one, a staff member, one-on-one every day, Monday through Friday, to restore their competency. The second track is just a general track for those that will stay on the ward and might take a little longer. Maybe it's just readjusting their medications. And then there's certainly those that may never be restored to competency. But my point is that we offer restoration classes Monday through Friday, and it's quite a team effort. And central office is working hard to unify and have each of the 10 hospitals provide a stronger program for restoration. And let me say this about state hospitals. They're the best kept secret in psychiatry for many reasons. One of them, there's obviously no pressure to discharge. And of course, I'm speaking about civil commitment patients, not 46B forensic patients. Private hospitals, the length of stay is based on their ability to pay. Am I talking too loud? I hope not, because it's, all right, good, because it's deafening. Anyway, the state hospital system has access to all the latest and best medications. It's no longer a place where, like, old docs go out to pasture, and that, which might be my case, actually, but we have 20 full-time psychiatrists at Terrell, and they're young and they're sharp, very sharp. We have 3 fellowship-trained forensic psychiatrists, one of which is faculty at UT Southwestern, their fellowship program for forensic psychiatry. So I guess to steal from the conclusion of the presentation, Terrell is unique because we get so many walk-in admissions and emergency detentions, it fills our beds, and we don't have enough room for the people in jail waiting on an open bed. And I can give you some kind of relativity here. We average at around 130 to 140 admissions a month, whereas, let's say, Austin State Hospital, in a month, their numbers are like 8 to 10. 8 to 10 admissions in a month, and we do that almost in a day. So it's like having a Ferrari in the garage and you can't drive it. Our competency restoration system is so strong, but yet it doesn't get fed the way it needs to be fed because we have so many walk-ins. I mean, we're looking at as many as 30 admissions a week, and it fills our beds, and we do have a limited capacity. In fact, we've stretched our beds to the maximum right now. Our child and adolescent unit is the largest amongst the state hospitals. There's 35 beds, and it normally stays over capacity, over 40 child and adolescent patients on a 35-bed capacity unit. So with that said, we do probably have more civil commitments from the community than we do forensic patients if you compared us to the other state hospitals. But the state hospital being the best kept secret, basically, no pressure to discharge, can have the best meds, and we get to teach. We have students and residents and fellows from 3 academic centers, UT Southwestern in Dallas, UT Tyler, and University of North Texas in Fort Worth. And the academic environment is wonderful. Myself, I love to teach, and it's just a win-win having students. It keeps you on your toes. So notice I haven't moved one slide, and that's fine. I kill y'all with slides. Anyway, the assessments for competency you have to consider, is there malingering involved? That's an issue. How do hospitals handle that? Will the patient receive the meds that you stabilize them on once they return to the jail? You know that a lot of the jails, they hire out their medical care. Some do it themselves. There's different models of medical and psychiatric care at the jails. And many of these meds are brutally expensive. So that can be a barrier for the jails that have a formulary where some of the newer, more expensive drugs are restricted. Anyway, some of the other issues, and maybe I should have my slides, it would help me. The adult units that we have, we cover geriatric, long-term, certainly forensic, but we don't yet have maximum security. And fortunately, the legislature appropriated money for new hospitals, and we're fortunate to be on that list. They're actually demolishing buildings as I speak at Terrell to build a brand new hospital. Certainly, hopefully you're aware of the one in Austin and San Antonio. They're beautiful, modern buildings. Rusk also has a new facility. So the state legislature is trying to address more maximum security beds. And we, upon the opening of our new hospital, will have 50 maximum security beds. And I don't know if numbers have been mentioned, but I remember just pre-COVID when the wait list in Texas was around 500 to 600. And that was very disturbing and alarming to central office. And the thought that it would go over 1,000 was horrifying. But yet, at the end of 2022, it went all the way up to 2,500 Texans waiting on open beds at state hospitals. Unfortunately, over the past year or two, it's dropped down, and now we only have approximately 1,600, which is still far too many. And all of the state hospitals across the country are facing this issue. Some have been punished by the federal government for not providing quick enough transfer of patients from the jail to the hospitals for restoration. I'm not sure where Texas stands on that, but we sure have a big waiting list. Anyway, the state hospitals all really face the top 3 problems of staffing and money, aggression by patients against staff and each other, And yes, the big one is the clearinghouse list. And I've been fortunate to talk to many superintendents across the country, particularly in the southern part of the country, and everyone's facing the same issues. So back to the Terrell issue and all of the walk-ins, the Dallas community is not as organized, psychiatric, mental health community is not as organized as, let's say, our neighbor in Tarrant County. They're very close to us, and yet their system is very well run. And I've never met Dr. Carol Natty, but she's got it going on. I know she's here somewhere today. Very well run, very organized. The Dallas system is a herding cats phenomenon because it's hard to get everybody at the table together and work on where do the police bring emergency detentions and what is the nearest psychiatric center and things like that. As far as walk-ins, a lot of ours is due because of our large child and adolescent unit, but it's also, we've got to help our LMHA strengthen their ability to divert patients from our admissions area. And that's, I'll try and be nice. That's a challenge. We really need more help diverting patients from our admissions that could maybe go to other centers. And I remember someone up in front here asked about in-jail competency restoration. That's where it's at, y'all. That's a big deal. That's just anything we can do to strengthen that will knock the waiting list numbers down tremendously. There's so many people. They're getting their meds. Maybe they're stabilizing while in jail. And it would just take a little bit of nudge, coaching, teaching to get them competent. And I know there's been areas in Texas that have that in place, but the bigger cities, Dallas, we have to have or really need a stronger in-jail competency restoration. It would have quite an impact. Some of them, of course, it's going to take a lot. Let me bring up another perspective from the psychiatrist's point of view. I was on the ward for 6 years. I was on an all-adult male ward, and they used to call it the gladiator ward. I don't think that's a flattering name, but it was an all-male unit, a lot of fresh admissions, so there was a lot of aggression. The point is, from a psychiatrist's point of view, there's an ethical dilemma of I've got forensic patients and I've got them competent now, but we haven't really completely normalized or treated their psychosis. So you as a treating physician are left with, do I go ahead and send them back to the jail to face their charges, or do I keep them a little longer to hopefully bring them back up to their best baseline level of functioning? And I don't think you're going to hear many people talk about that. That's probably one of the more quiet conversations. But it's a dilemma, and everyone may share or have different thoughts on that, but a lot of psychiatrists come out of residency and they've never dealt with forensic patients and these issues, and their focus is to maximize that patient's treatment. And I think you could argue it either way. There are people that would feel very strongly, don't keep them. The moment they're competent, send them back. I don't have the answer to this dilemma. I'm just making you aware that that can be an issue. So long-acting injections are wonderful. There's newer meds on the market. There's actually a brand new medicine on the market now, and we're all eager to see if it works because it's so different than all the other meds. It works by a different mechanism to treat psychosis. All of the current antipsychotics we have available, and that's quite a list, of that group, the newer ones are just old wine in a new bottle. They all work essentially by the same mechanism in your brain. And so we're very, very hopeful this new medication works well. And then there'll be copycat drugs that mimic that mechanism of action, and we'll be able to better treat the positive symptoms of schizophrenia, hallucinations, delusions, impaired reality testing, all of that. And I hope y'all have questions, because we love questions. If we can break for questions. Thank you.
Hi, Dr. Messer. I have a very high opinion of Terrell State Hospital, by the way. I represent almost exclusively clients in competency restoration programs as a defense attorney, and I love the work that's done at Terrell. But I am curious what you said about someone who is opined restored to competency and yet still remaining in active psychosis. Because I guess from my perspective, when I interact with a client where that opinion has been rendered, their active psychosis is interfering with competency, particularly that ability to consult with counsel. So just kind of what are your thoughts on that? And how do you see someone being able to be opine competent and yet still needing psychiatric treatment for psychosis to get to a baseline?
That's a great question. It speaks to the complexity of the illness, because you can have someone that can give the role of courtroom personnel. They can name their charge, their plea options, what they're going to plead, all of those things. They can even discuss their case in a rational manner, but yet maybe they have horrible auditory hallucinations. Maybe they have fixed delusions that are often paranoid in nature. So is there a bar, a level of improvement in their condition that we would all agree on? So the same patient at 5 different hospitals might have 5 different decisions on whether they are or are not competent. And that just reiterates my point, is as a treating clinician, how do you ethically decide what's the greater good? So yeah, they're not competent. If real technically, I guess I don't know the law obviously as well as many here. If they can't work with their defense attorney, I mean, that's not really competent, and it defeats the purpose of the whole restoration program. I don't know if that answered your question, though. Yeah, I hate to hear that. I mean, if there was a case like that at Terrell, you could call me. You can sound the alarm, and we will absolutely bring them back and take a better look. That would not be a problem. Well, that's good. Yes, sir.
Yes, I'm Dr. Smith, forensic psychiatrist. Could you clarify when you first opened, you gave some numbers. You said at Terrell there's a certain number of beds, but then you said there were, I think you said there was one number that was 200 and something, and then there was another number that was 300. And it made it sound like there was available, like all the beds weren't full.
We are licensed for 305 beds, but yet our current census is around 210 to 220. We've had, unfortunately, some structural damage and erosion to the foundation of several of our patient buildings, where the engineers have deemed them uninhabitable by patients. So that's caused us to have to really crunch how we house and where we house the patients.